असणार आहोत. ही वेबिनार सिरीज कशी असेल, क्लिनिकल फार्माकोलॉजी मध्ये आपले कंटेंट काय असणार आहेत, या संदर्भातच आज चर्चा करण्यासाठी आजचा वेबिनार घेतलेला आहे. तर ह्या वेबिनार मध्ये आपल्या सर्व शंकांचं निरसन निश्चितपणे होईल. ऍड देत असतानाच आपण करिक्युलम आपल्या सर्वांसाठी दिलेला आहे. करिक्युलम मध्ये आपण काय काय ते असणार आहे त्याचे कंटेंट डिटेल दिलेले आहे. एक महत्त्वाचा विषय असा आहे की एक रेग्युलर क्लिनिकल फार्माकोलॉजीचे टॉपिक्स ज्या पद्धतीने आपण कॉलेजमध्ये शिकलो किंवा पाहतो त्या पद्धतीने असेल असं नाही, तर एक क्लिनिकल अप्रोच ठेवून आपण मॉड्यूल हे तयार केलेलं आहे. प्रॅक्टिकल, कारण मोस्टली आपले सगळे जे आहेत ते प्रॅक्टिशनर आहेत. त्याचबरोबर CCMP अफेअर असणारे काही मेंबर आहेत. यांना कशा पद्धतीने हे करिक्युलम उपयोगी पडेल, हा क्लिनिकल फार्माकोलॉजीचा एकूणच वेबिनार जी सिरीज आहे ती कशी उपयुक्त ठरेल, अशा पद्धतीने मॉड्यूल याचं तयार केलेलं आहे. त्याचे रजिस्ट्रेशन सध्या चालू आहे. रजिस्ट्रेशन करत असताना बऱ्याच जणांचे प्रश्न आम्हाला येत होते की सर याच्यामध्ये कंटेंट काय, करिक्युलम कसा आहे, तो कशा पद्धतीने कंडक्ट केला जाणार आहे किंवा प्रॅक्टिसिंग डॉक्टरांना त्याचा कसा उपयोग होऊ शकतो, किंवा मोस्टली अगदी 25-30 वर्ष झाला मी प्रॅक्टिस करतोय, तर आता आपल्याला खरोखर एक क्लिनिकल फार्माकोलॉजीचा स्टडी करणं तितकं शक्य आहे का, किंवा करणं तेवढं आवश्यक आहे का, किंवा त्याच्याबद्दल काही फोबिया आहे. कारण बरेच वेळा कॉलेजमध्ये थोडासा बाजूला राहिलेला किंवा न आवडता विषय असणारा फार्माकोलॉजीचा हा विषय पण किती इम्पॉर्टंट आहे, ह्या गोष्टी आपल्याला आजच्या या वेबिनार मधून समजून येणार आहेत. तर आम्ही अगदी मुद्दाम सरांना, शंतनू सरांना विनंती केली की आपण काय देणार आहोत किंवा काय क्लिनिकल फार्माकोलॉजी बद्दल आपल्याला माहिती असणं गरजेचं आहे, आणि एक प्रिस्क्रायबर आपण म्हणू अशा पद्धतीने आपल्या एक प्रिस्क्रिप्शनला वेटेज कशा पद्धतीने प्राप्त होऊ शकतं. तर एक प्रॅक्टिकल अप्रोचने आपण कशा पद्धतीने देणार आहोत ह्या गोष्टी आपण ह्या वेबिनार मधून सांगूया. तर सरांनी त्यासाठीच हा वेबिनार आजचा घेण्याचं मान्य केलं. तर प्रथम आपल्याला डॉक्टर शंतनुनार जोशी सर आपल्याला मार्गदर्शन करतील. ते क्लिनिशियन आहेत, फार्माकोलॉजिस्ट आहेत आणि ड्रग रिसर्चर आहेत. गेले 20 वर्षाहून अधिक काळ यांना ह्या क्षेत्रामधला अनुभव आहे. त्याचबरोबर आपल्याला माहिती आहे की आपल्या सर्वांचे आवडते सर, आपले मेंटॉर ह्या UAMचे डॉक्टर पद्मनाभ केसकर सर त्यानंतर आपल्याला मार्गदर्शन करणार आहेत की क्लिनिकल फार्माकोलॉजी नेमकी आपण कशा पद्धतीने स्टडी केला पाहिजे, डे टू डे प्रॅक्टिस मध्ये त्याचं इम्पॉर्टन्स कसं आहे, ह्या दृष्टीने ते मार्गदर्शन करणार आहेत. त्यानंतर मग अगदी सगळ्यात शेवटी आपले काही प्रश्न असतील तर त्या प्रश्नाचे आपल्याला उत्तर मिळतील. सगळ्या क्युरीज आपल्या क्लिअर होऊन जातील. आणखीन कशा पद्धतीने वेबिनार सिरीज घेतली जाईल, त्याचं शेड्यूल कशा पद्धतीने असेल किंवा रजिस्ट्रेशन फॉर्मॅलिटीज कशा आहेत त्याबद्दल आपण शेवटी चर्चा करूया. तर फार वेळ न घेता मी डॉक्टर शंतनुनार जोशी सरांना मी विनंती करतो की त्यांनी आजचा जो टॉपिक आहे लर्निंग क्लिनिकल फार्माकोलॉजी अ की ऑफ सक्सेसफुल मेडिकल प्रॅक्टिस, असं टॉपिक आज आपला आहे. त्या संदर्भात सरांनी मार्गदर्शन करावे. शंतनू जोशी सर प्लीज कंटिन्यू करा. आवाज पोहोचतोय?
Yes. Now you will be hearing me because someone muted me. Am I audible? Am I audible? माझा आवाज येतोय का आपल्याला?
Yes sir, yes sir.
सगळ्यांना येत असावा?
हो येतोय सर.
कॅमेरा ऑफ आहे सर.
धन्यवाद धन्यवाद धन्यवाद. Let's start the topic. The topic given to me.
संतोष तू कॅमेरा व्हिडिओ ऑफ ठेवलेला आहे आमचे, त्यामुळे आम्हाला चालू नाही करता येते बिकॉज द होस्ट हॅज स्टॉप्ड इट.
बघता येतोय मला?
हा हा शंतनू सर तुम्ही आता तुमचा व्हिडिओ चालू करा.
माझा व्हिडिओ चालू आहे सर ऑलरेडी.
हो पण तो इथं स्ट्रीम नाही होते.
ओके सर, जस्ट अ मिनिट. कुठे दिसेल रे? इकडे पटकन मला जायचं का? Is it okay now? परत PPT करू. दिसतोय मी आता?
हा
हो
सर.
दिसतंय.
I think everything is okay now. I think I should start. Should I start?
येस सर.
Yes. Thank you. Today, the topic given to me is this learning clinical pharmacology. The basic question asked by many members, why one should learn clinical pharmacology being a practitioner. What is the need of learning pharmacology though you are in practice? There are many people who are having excellent practice, and still we are of the opinion that yes, pharmacology need to be learned by every practitioner. Why? You may be thinking that I learned it in my college days, but many days I had passed and many changes in medical sciences took place during that period. And that is one of the reasons that one should learn pharmacology even at completing over 10, 20 years of the practice. What is this pharmacology? A pharmacology is nothing but a drug science. Everything related to the drug. Simple language, drug science. It is the drug science. All related with the drugs that you need to study in this pharmacology. What does it mean to a doctor? For a doctor, it is required by every doctor, every branch. You are a cardiologist, you are a general practitioner, you are a general physician, you are urologist, you are gynecologist, you are pediatrician, whatever the branch you are from, you need pharmacology. Every day and with every patient, you need pharmacology. Each prescription you need pharmacology. In each prescription you need pharmacology. Every time you need to select the drug from the group of the drugs. Many times from the groups and many times within the group. You have to select that drug. All that is required the basic understanding of this subject. Now, I should tell you, though we are saying that we are learning clinical pharmacology, still I should make it clear what exactly we are going to learn. Basically, pharmacology is divided into experimental pharmacology. That experimental pharmacology is a part of preclinical development of the drug. It is more related with the drug research. And that is one of my area of working also. That is what we call experimental pharmacology, where we develop the drug, we test those drugs in animals. And that is why we call it experimental pharmacology. And this experimental pharmacology later converts into human pharmacology, but we do not use the word human pharmacology. We prefer to use the drug clinical pharmacology. Now, I should make you clear that clinical pharmacology is also the testing of the drug in humans. Testing of the drugs in animal is experimental pharmacology. Clinical pharmacology is the testing of the drug with the 4 phases, phase 1, phase 2, 3, and 4 in human. That is clinical pharmacology. Now you may be thinking, Dr. Joshi, you have given the name. That is only for the understanding purpose. What you people are interested, what a doctor is interested in, pharmacotherapeutics. What you want to learn from me is the pharmacotherapeutics. Whenever we get the knowledge from the clinical trials and the drug get approved in the market, it is available in the market, then we apply that clinical knowledge with that knowledge generated through the experimental pharmacology and the clinical pharmacology, we use it in therapeutics. And that is the part, that is the application of the pharmacological knowledge in the therapeutics. application of the clinical pharmacology knowledge in therapeutics, in the clinics. That is the part you want to learn from me. And this is really a very interesting part, because whatever the efforts the companies put together end up into the clinical use of the drug. And that clinical use of the drug is pharmacotherapeutics. It is the clinical application of the pharmacological knowledge. By the way, I should tell you that this is the phase 1 unit at the Department of Clinical Pharmacology where I'm working now. Now, pharmacology is having its branches. The very simple words I should tell you. One branch is pharmacokinetics. Pharmacokinetics means the movement. The word kinetics means movement. Movement of the drug. What is the movement of the drug? You take the drug. Then the drug will first disperse. Then will get absorbed from the gastrointestinal tract, if that is the way of giving the drug. Then will be distributed all over the body, because the drug will move to the blood. Blood will be distributing the drug all over the body. Some drug will remain in the blood. Some drug will be moving to the tissues. In the tissues, it will be acting on the cells and like that. The first is the absorption of the drug. Then there will be the distribution of the drug. Naturally, drug is a foreign particle for the body. It is a foreign substance for the body, and that's why natural tendency of the body is that this drug coming in the body is going to interfere with the functions of the body which are going on there. And that's why natural tendency of the body is to degrade the drug. That is what we call metabolism of the drug. And naturally, after the metabolism, the drug needs to be excreted from the body. This is the movement, absorption, distribution, metabolism, and excretion of the drug. That is known as ADME of the drug. AD, this is the absorption of the drug. Then there is distribution of the drug. Then there is metabolism of the drug and excretion of the drug. This is kinetics. You may be thinking, sir, why I require all these things? In a nutshell, I should tell you, in very simple language, I should tell you, if your drug is like adrenaline, you cannot give it by oral route. You have to inject that drug, because it is having such a chemical structure, having one catagon nucleus there, which is susceptible to this liver. Liver is having one enzyme, COMT, catechol-O-methyl transferase, that degrades the adrenaline molecule. And that's why there are certain drugs, those cannot be given by oral route. That has to be understood with the help of this pharmacokinetics. Some drugs you give 2 times in a day. Some drugs you give 3 times in a day. Some drug you give once in a day, and sometimes you give the drug once in a week, like methotrexate. Why? That why you will understand in this kinetics. You will understand the binding of the drug to the proteins, binding of the drug in the tissues, how it is metabolized. If the drug is to be metabolized by the liver and the patient is having a liver disease, you have to reduce the doses. When the drug needs to be excreted through the kidney, when the drug needs to be excreted to the kidney and patient's creatinine value is suppose 4, then you have to reduce the dose according to that creatinine clearance. This is the dose adjustment according to the creatinine clearance. For that, you must know whether the drug is to be excreted by the kidney or whether to be excreted by the bile or by any other route. Some drugs are also exhaled. For that purpose, for the understanding of this, all these applications of pharmacology, you need to understand this branch of pharmacology, that is pharmacokinetics. Now, the second part that is more important, and that is pharmacodynamics. Dynamics means change. What change the drug is going to bring about in the body. For making any change in the body, the drug has to bind somewhere. The drug has to bind somewhere. This binding of the drug to its specific site, generally it's a receptor, but not always it's a receptor. The site of binding is generally a receptor, and that is known as action of the drug. Just binding in is known as action of the drug. When the drug is going to bind to the cell, it will alter the function inside the cell. When the drug is going to bind to the cell, it will going to alter the function of the cell. That alteration will be called as effect of the drug. Action is just binding. Not every time the action will result into effect. Sometimes it is just going to block that receptor. That is what we call antagonist. But when it binds and results in some action, that is what we call action effect sequence. That action effect sequence is to be studied in this dynamics. One more part of dynamics is related with the quantity of the drug and the quality of the response. My point is important. Quantity of the drug and the quality of the response. Generally, you increase the quantity of the drug and the response increases, but this is not always true. You can take the example of aspirin. Aspirin at a dose of 75 milligram, 150 milligrams will give anticoagulant, antiplatelet effect. But the same aspirin at the dose of say 900 milligram, 1000 milligram, 3000 milligram, where we use it in the dose of anti-inflammatory doses, the antiplatelet effect is not seen. I'm repeating. The antiplatelet effect of aspirin is seen only in the doses of 75 milligram to 150 milligrams. It is not seen at higher doses. If you want to study all these things, you must know the dynamics of the drugs. I'm just giving you little examples, simple examples, so that you will understand why it is necessary to study it. Now, this is all the details of that drug, but I need not to go in detail of it now because this is not my part of discussion today. I'm just going to give you the idea. Why one should learn pharmacology properly? My very simple question to all of you participants, are you really confident while you are selecting a drug, while you are prescribing a drug? Are you really confident that yes, my choice of the drug is the perfect choice? And you may be thinking, Dr. Joshi, I write a drug, but I'm not too much confident. Then you may be asking me, Dr. Joshi, how I will be confident? I can be confident. The answer is very simple. You must know the basics. I am a firm believer that everyone who wants to study pharmacology should have basics, clear basics. You cannot build a building over a poor platform. It is not possible. You must have very good basics and then you can build up a very excellent building over it. If you are not confident enough, then you should learn it. What should not be used is very important. Many times you know what is to be used, but you must know that what should not be used. I'd like to tell you a very simple thing that you might come across in the OPD. Patient is many times on digoxin, and you may need to give beta blockers for some other purpose. But this combination is not an allowed combination. This is a contraindicated. Combined use of these two drugs is contraindicated. In a similar way, the calcium channel blockers, especially the calcium channel blocker, which are cardioselective, verapamil, deltazim, that should not be combined with beta blockers. In my opinion, you may or may not know where to use, but you must know where not to use, because not to use leads to the complications. Not to use leads to the complications. I just given you one example that digoxin should not be combined with beta blockers. Then you know this thing, but you still don't know why they should not be combined. It is because of the fact that both of them are going to reduce the heart rate. If you are giving two drugs at a time, they may give you cardiac asystole. Yes, the mechanism of action is different. That I will tell you during the lecture series. Once you know those basics, then you will not combine it any time, by chance even. Remember my words, why of the drug. There are three components. What is to be used in the clinical practice, How is to be used in the that drug? What is to be used? How is to be used? But most important is why is to be used. Why that particular drug you are going to select? Why not the others? That why of the drug. That is what I used to say the words brain behind a drug. That brain behind a drug, if you want to understand, you should study this pharmacology. My simple questions to all of you, are you really logical in selecting a drug? Let it be antibiotic, antimicrobial agent. You go on changing, you go on combining. You tell that there is resistance, resistance, and resistance. But really, are you selecting that drug perfectly? I came across the people prescribing Suffixes for skin infections. They are not at all related. Not at all related. Suffixes is selected in upper respiratory tract infection. It's a wrong choice. They are not related. Suffixes is from third generation cephalosporins. The principal spectrum of activity is gram negative. The same Suffixes you can select elsewhere, that is in UTI. That's a good choice. You can select Suffixes in lower respiratory tract infection where there is sensitive organism to it, and that is Streptococcus pneumoniae. It covers Streptococcus pneumoniae. But for that, you should have some basic knowledge of that microbiology, the spectrums, selection of drug, how antibiotics are selected. And I think that this antibiotic stewardship is really, really needed in the clinical practice, really needed. We are the people on the planet Earth producing n number of resistant antibiotics. It is just because we don't have stewardship towards that selection of antibiotics. I think that this might be the major thing I'm going to tell you about how we select a drug, how we select a. For that, you need to go in details of some part of microbiology, the flora, gram positive, gram negative, and all that. But that is really needed. And you will not select in the situations where I told you about Suffixes. Because I come across many people prescribing the drug for these purposes and telling me that, Dr. Joshi, it won't work. I'm thinking that how it will work. It is not meant for it. And you are selecting it because you don't know from where that Suffixes is coming from. What groups are there in Suffixes? If Suffixes is not working, should I use cefodoxime? Is another question. If I say yes, then you may ask me, sir, why? Then I will be giving to the details of its chemical structure and tell you a very simple thing that this is present and this is absent. And that's why we can select it. Now, are you really know the basis of drug prescribing? Rational drug prescribing. Yes, WHO is repeatedly telling to the world that your selection of the drug must be a rational selection. How we should select a drug, rational drug. Many times, don't take me negatively, but this fellow, medical representative, is a source of information for the doctor. I'm not against the medical representatives, but the knowledge must come from a research paper. Yes. I must tell you this thing, the latest edition of the book is at least 5 years back in the knowledge. If you want to have the current knowledge, research paper through a good journal, proper journal, is the only source of and the best source of information. During my lecture series, I'm going to contribute from that because this is my habit. Medical representative. Now, many people lacking this thing, confidence. So I'm practicing, I'm having good OPD, but when I write, sometimes I have to torn that prescription. I have to make another prescription. Why it happens? Why confidence is not there? Do remember, dear students, dear colleagues, confidence comes only from the knowledge. Where to use, how to use, and why to use. Why to use comes from the knowledge. And for that, you need to learn pharmacology from its base. That basics are very important. Many times you find that the prescription are being just copied. They even don't change the trade name. But you cannot copy a prescription because clinical condition, comorbidities of the patient changes from patient to patient. Age changes, gender changes, comorbidity changes, ongoing medications are there, drug-drug interaction is there. All you need to consider while prescribing a drug. And that's why some senior fellow is prescribing something, or where you underwent your so-called internship, those people are putting some prescription for some purpose, and you are just copying that prescription. Is it a way? No. Why you are copying the prescription? Because of a very simple thing. You don't know that why. You know what is to be given, you know. How is to be given, twice a day, thrice a day, how the doses are to be managed, you know. You know what, you know how, but you don't know why you are prescribing it. And that why comes only through knowledge. It comes through basics. And that is needed, really needed in the clinical practice. Already I told you about this thing. You know what, you know how, but generally this is a query. Generally you don't know why. Sometimes you know, sometimes you don't. But one has to concentrate on this why I'm selecting this drug and why I'm not selecting the other drugs related to this disease or whatever the clinical condition of the patient is. If you can, then really it is worth. What should not be used? The why and why not comes only from the basic understanding of pharmacology. And this is the reason, dear colleagues, you must understand pharmacology in its own way. Learning from the book carries zero meaning. You can't learn pharmacology. If it is so, you all are having the books at your clinics and you would have learned it very earlier. But this is not the thing. For that, you need to go through basics. Once you know the basics, then learning a drug is a very, very simple thing. Yes. Now, there are indications of the drugs. General indications you generally know that azithromycin has to be used in LRTI, URTI, based on the basic spectrum is gram positive. It covers the gram positive spectrum. But rarely you know that this erythromycin, I'm talking about azithromycin, I given the example, and now I'm talking about erythromycin. Erythromycin is a prokinetic drug also. It increases the peristaltic movement and is useful for emptying of the stomach. Reflux, esophagitis reduces with the use of erythromycin. This is also an indication of erythromycin. Then you know chloroquine. You know chloroquine is anti-malarial. But chloroquine has many roles. One of the role is in photosensitivity. It's a drug of choice in photosensitivity. The same chloroquine is very useful by its another side, that is hydroxychloroquine, in rheumatoid arthritis. These are also indications. But you may know or may not know. You may know that quinine is a spermicidal drug. You know quinine as anti-malarial. The same quinine is used in night cramps. Many uses are there. It is a non-dependable abortifacient also. Yes. The only safe drug in the pregnancy is chloroquine. So far anti-malarials are concerned. Others we use by taking risk. And that is what we call risk-benefit ratio. That I will talk to you later. Doxycycline is also anti-malarial drug. It's not a selective anti-malarial. But yes, it is having one of the properties anti-malarial, doxycycline. All of the tetracyclines group of drugs are affecting the kidney. This is the only doxycycline which do not affect the kidney. Yes, one methyl group is absent there. And that is the reason why it doesn't affect the kidney. Renal function is not affected by doxycycline. All other tetracyclines are nephrotoxic, except doxy. But this all knowledge will come only through basics. That is important and repeatedly telling you. You know propan acid. Propan acid is used to retain sulfalaxin because it blocks that organic anion transporter. This is the organic anion transporter. It is blocked by propan acid. Actually, propan acid is being filtered from this organic anion transporter. It is utilized for propan acid. And that's why sulfalaxin, which is also moving from the same direction, from this direction, the propan acid will be retained and sulfalaxin will be retained. Propan acid will move. It will acquire the place of sulfalaxin. And that's why sulfalaxin will remain in the blood for more time. And that's why if you prescribe sulfalaxin with the trade name of Sporidex, you have to give it 3 or 4 times a day. But if you are prescribing it with propan acid, you have to give that twice in a day. Cephalong is a trade name available in the market. Cephalong. Sulfalaxin has to be given twice because cephalong contains propan acid plus sulfalaxin. And this is the way this organic anion transporter, that is a pump that is being used for propan acid. It remains engaged for propan acid and will spare the sulfalaxin. This is just, I'm giving you oral just introduction to it. This I will explain in detail with you. The same propan acid will reduce the reabsorption of uric acid because the same transporter is there. While propan acid is being moving from this place, uric acid cannot move from the reverse direction. It cannot be reabsorbed. And that's why uric acid excretion increases with the same mechanism. The propan acid makes sulfalaxin long acting. The same propan acid is useful in the gout to reduce the uric acid. Same propan acid. Just I'm giving you why this is important and how indications come. Now I'm talking about contraindications. Contraindications, beta blockers are contraindicated in asthma. You should not use beta blockers. You may select selective beta 1, but they are partially selective. Atenolol, metoprolol you can use, but that too with caution because they also affect, but they can be used because their beta 2 effect is minimum, beta 1 effect is high. For that, you need to understand beta 1 and beta 2, and for that, you have to go in details of adrenergic nervous system. When I am talking about adrenergic nervous system, you must know what is adrenergic and what is cholinergic. For that, you must know autonomous nervous system. Once you know all these things, then it's very simple. Why we are not using it in asthma? Why we try to avoid it, use of beta blockers in asthma? It is because of its beta 2 activity. Beta 2 activity is related with bronchodilation. When you block using beta blocker, that beta 2 activity, if get blocked, it will produce bronchoconstriction. I'm just giving you the idea about it. AC inhibitor, ARBs are contraindicated during pregnancy, but this contraindication is a strict contraindication. You should not use it. This is relative contraindication. You may use or may not use it. You may use it with caution, but this is not possible with AC inhibitor or ARBs. During pregnancy, you must not use it because it is related with fetal renal agenesis. Fetal renal agenesis is well known. I have reported the case from KM when I was in my post-graduation. I was reporting from to PVPI, that is Pharmacovigilance Program of India. It's an absolute this is relative contraindication, this is absolute contraindication. How it is to be decided? What is risk-benefit ratio? Many times we select a drug, we know that this drug is contraindicated. But a clinical situation is that giving the drug, the risk is lesser than the benefit we are getting. And this is what we call risk-benefit ratio. You may use a drug which is contraindicated in a situation where your risk is lesser than or a benefit outweighs the risk. Yes. I told you on malaria. All other drugs are actually contraindicated. You should not use other drugs. They are having some this and that problem. Only chloroquine can be used. But I am having the patient who is chloroquine resistant. And I have to use the other drug. And will you use that drug that is going to affect the fetus? Yes, I will use, because survival of mother is very important in that case. If she is having the problem, the fetus is ultimately going to die. We always give more importance to mother than the fetus. Yes. Because mother's life is an established life. Fetal life is unestablished life. In simple language, mother cannot be regenerated, but baby can be reborn or regenerated. Yes, birth of the baby can be repeated. Birth of mother cannot be repeated. And this is how we decide it according to that. Now, the patient who is on phenytoin sodium, the patient is on the antiepileptic drug phenytoin. She is taking phenytoin since long time. Now she is married and she wants to take oral contraceptive pills. But in such a lady, oral contraceptive pills should not be used. Then you may ask me, because both of them, that is the estrogen and progesterone, this is OCD. It requires P450. I'm not going in detail of it. This is the enzyme required. Phenytoin also require the same enzyme. Now patient is taking phenytoin since a long time. I already told you. And phenytoin is an enzyme inducer. That is the category of the drug, enzyme inducer. What is that? It increases the enzyme required for itself. It increases the quantity of the enzyme required for itself. And that's why P450 will be higher in the blood. Now, if you are using estrogen and progesterone combined, already P450 is high. And that's why degradation of estrogen, degradation of progesterone will be faster. And there will be contraceptive failure. And that's why when a lady is on phenytoin, phenobarbital, carbamazepine, all three are enzyme inducers. That lady should not be treated with oral contraceptive pills. Contraceptive failure is a great possibility. For that, you must know this P450. I have just given you the example of the whole broad P450. P450 is a group of enzymes. 3A4 is actually the working enzyme, 3A4. But for that, you need to understand what is that microsomal enzyme system. That I will explain. A patient is on ART, antiretroviral treatment, but a patient is also having tuberculosis. And during tuberculosis, you use rifampicin. Rifampicin is also enzyme inducer. In that case, you cannot use the two important group of drugs. That is protease inhibitors and NRTIs. This is a group. Efavirenz and that those drugs should not be used. Why? Because this rifampicin is going to degrade them. It's an enzyme inducer. Have you come across the case in the clinic where treating asthma, the patient develops diabetes? You are treating patient of asthma. You are loading the drugs of asthma. And you find that the sugar of the patient shoot up. He is the patient of diabetes really? He is not the patient of diabetes. Because you are given drug which is going to dilate the bronchus, is acting on beta-2 receptor of the bronchus. And that's why bronchus is being dilated. But a same drug which is acting on the beta-2 receptor of the liver, stimulation of beta-2 receptor of the liver converts glycogen to glucose, and glucose level in the blood rises. And that's why when you are treating a patient of asthma, especially by the drugs, by IV drugs especially, the drugs are going to dilate the bronchus by beta-2 activity. The same beta-2 activity acting on the liver converts glycogen to glucose and the blood sugar level rises. He is not a patient of diabetes. It is iatrogenic diabetes. You are creating it. Iatrogenic means doctor is going to create it. This knowledge you will get only after understanding of basics. If you don't have the basics, then it's very difficult. How I told you. Should you use beta blockers in diabetes? The same problem is that. My patient is a patient of diabetes. He took little, or that is a day of fast. He took little खिचडी, साबुदाण्याची खिचडी घेतली पेशंटने छोटीशी आणि गेला कामावर. उपवास असल्या कारणाने तिथे जाऊन धापकन पडला. काय 10 वाजता खाल्लं होतं, 1:30 वाजता पडला. 1:30 वाजेपर्यंत शुगर होती त्याच्याकडे गोळीचा परिणाम झाल्यामुळे. आता तो खाली पडल्यानंतर त्याला बाहेर यायचंय हायपोग्लायसेमिया. तर बॉडी काय करते? What body does actually, it converts glycogen to glucose by its beta-2 activity. But a same patient of diabetes to whom you are giving these beta blockers, if you are using beta blockers in the same fellow, its beta-2 activity will be suppressed. Conversion of glycogen to glucose will be affected. It will not be done immediately. And the recovery of the patient from hypoglycemia may not be proper. And that's why it is better to avoid the beta blockers in the patient of diabetes. But do remember my another word also. This is not going to happen daily. Hypoglycemia in diabetes is not a daily thing. And that's why it is not a strict contraindication. It's a relative contraindication. Try to avoid it. It's not contraindicated. But once you know that beta-2 activity affecting the sugar, you will try to avoid the use of beta blockers in the patients of diabetes. If better choices are available, you will choose that other drug. And if no other drug is available, then you will use the lower dose of beta blocker to avoid this complication. But you will understand all those things once you understand beta-2. Once you understand beta-2 effect on the liver. Otherwise, it's not possible. Can you use beta blockers in congestive cardiac failure? Actually, they are contraindicated. That is what is written in the book. But it is only for the decompensated persons. In a compensated CHF, for the long-term purpose, survival of the patient increases with use of beta blockers, especially with metoprolol. Studies available. Then you may ask me how. It is related with the basic pathology that is going to revert with the use of beta blockers. I need to tell you the basic pathology of CCF in detail, how it affects the the renin-angiotensin system and the adrenergic system, how they play the role when the heart is hyperdynamic, and how use of the beta blockers can increase the survival of the patient if the patient is in the compensated CHF. When the patient is in decompensated CHF, we should not use it. But for that, you again need to understand the basics. Really, beta blocker remains the choice in hypertension today. I should tell you, it is the 6th choice. Beta blocker is not at all a good choice in hypertension. It's a last choice, second last choice. You may be asking me why, sir? Beta blockers are indicated only when some compulsion is there. A compulsion comes from anxiety. If anxiety is a cause, tachycardia is present in the patient. Yes. You know the signs and symptoms of anxiety are present in the patient. Then the choice of beta blocker is the only indication. Yes. These underlying factors, if present, then I will select only beta blocker. Otherwise, beta blocker is not a good choice in hypertension. It is not. Already I talked about Suffixes. I have given a good idea about Suffixes. The respiratory infection, you can use it, but low respiratory tract infection, it is related to Streptococcus pneumoniae. Is it really worth to use Suffixes in the skin infection? The answer is absolutely no. Absolutely no. Skin infections are typically due to Staphylococcus aureus, and it has no activity against Staphylococcus aureus. No activity, zero activity. That's why when you are prescribing Suffixes in that skin infection, it's not a good choice. And when you are using it and telling me, Dr. Joshi, it do not have effect, where is your antibiotic stewardship? You are not a rational prescriber of antibiotics. Is it really worth to prescribe azithromycin in the gynecological infections? The answer is yes. Yes. Some or gram-negative organism is affected by azithromycin, especially I'm not getting the name immediately, we'll tell you. Should azithromycin be combined with chloroquine? Actually, many times in the OPD you combine them. It's a risky combination. Why? because both of the drugs are going to reduce the QT. Sorry, prolong the QT. And prolongation of QT leads to arrhythmia anytime. I'm just giving you the overview. For that, I need to tell you the refractory period, the partial refractory period, and the complete refractory period of T wave, and how it lengthens and why, when it lengthens, how it affects the choice of the drug. Why we should not combine these two drugs. Now I just given you the example of this Suffixes. This group is known as amino-thiazolyl group. It is present in the Suffixes. And I told you at the time, when you don't want to use Suffixes because of the resistance, you are having another choice of cefodoxime. Why you can use cefodoxime? Because it is having random groups. Cefodoxime can be selected over Suffixes because of the change in the groups. I'm just giving you examples how the drug choice develops and how it is related with its SAR, that is structure activity relationship. How it is related. Just I'm trying to tell you. Actually, this is a big explanation. I'm just giving you the idea about it. What should be the choice of antibiotic choice in skin infection? Cloxicillin. It is known by the name anti-staphylococcal penicillin. Narrowest spectrum. Anti-staphylococcal. Staphylococcus aureus or Staphylococcus epidermidis are the only two organisms affecting the skin in 90%, 95% of the cases in a normal individual, not immunocompromised. And for that, anti-staphylococcal cloxicillin is the choice. You should select it and get the results. Then you may be asking me, sir, I am using ampicillin with cloxicillin, which is actually banned. It should not be used. Ampicillin, why you are adding ampicillin there? It's not an irrational combination for skin infection. But you will understand all these things once you know the basics. What are the principles in selecting the antibiotic? I should tell you many things while selecting an antibiotic in all type of infections. There are very, very basic rules. Once you know those rules, you will 100% select the proper drug. And you will tell me, Dr. Joshi, this very simple drug is working nicely, sir. I'm very happy with your classes. And some basics are required. And if you don't know the basics, you will never learn this pharmacology, neither the selection of these antibiotics. Now I'm asking you a very simple thing. My patient took, say, 10 tablets of Comeplan. I tried my best to take some drug out. Some drug came out by emesis, induced emesis or gastric lavage. And still I feel that like 2-3 गोळ्या त्याच्या absorb झाल्या, 4 गोळ्या absorb झाल्या. What should I do? You are having one choice to give Sodavacar. You may be asking me, sir, why you are using Sodavacar? The principle is very simple. That is again coming from the basics of pharmacology, that the alkaline acidic drugs are better excreted in the alkaline medium. You are making the urine alkaline by using that Sodavacar. While using the Sodavacar, you are making the urine alkaline. All of the NSAIDs are either acids or the derivatives of some acids, organic acids. Principally, all NSAIDs are acids. Acidic drugs are better excreted in alkaline medium. And that's why alkalination of urine is the principal therapy many times. Many allopathic drugs are acidic drugs. And few are alkaline. Now I'm using the same idea. But if my patient is having issue with pethidine, pentazocine, pethidine, opioid my patient took, that is also painkiller. Now, can you use the same idea of Sodavacar here? The answer is no, because these drugs are principally alkaline. Alkaline drugs are better excreted in alkaline acidic medium through the kidney. It is affect the ionization. I should tell you the whole story of ionization, that I will tell at that time. Now you should remember that this idea of alkalination of urine can be used for NSAIDs, non-steroidal anti-inflammatory drugs, but cannot be used for opioids. Opioids are not excreted. with alkalinization of urine. Rather, it will reduce the excretion of the drugs if you are making the urine alkaline. The similar thing I can tell you about dialysis. Can we use dialysis for this diazepam? Answer is no. Why? It's a highly lipid soluble drug. And the remaining drug remains bind to the protein. The principal thing you require in the dialysis to remove the drug by dialysis, the principal thing required is the drug must be an ionizing drug and must be available in its free form. Lesser is the protein binding for, more is the effect of the dialysis. For that, you must understand what is the process of dialysis. And then you will decide whether in this poisoning patient I should go with the dialysis or I should not go with the dialysis. I should tell you very clearly, there is limited role of dialysis in the drug poisoning. Practically, it is a limited role. It is having limited role in this. But for that, you must understand what is lipid solubility of the drug, how a lipid soluble drug can be made water soluble, how the drugs are excreted, how the handling of the drug takes place at the renal sites. All this is the part of basic. Once you understand it, you will immediately tell this will be excreted, this will not be excreted. Immediately, no, there is not much logic in it. But why gentamicin or other amine glycosides cannot be given by oral route? Have you ever seen a tablet of gentamicin? Have you ever thought that amoxicillin is available by tablet, azithromycin is available by tablet? Why gentamicin is not available by tablet? It is because the drug is highly ionizing. It is available as its sulfate salts. When you give the gentamicin, it dissociates at gentamicin plus and sulfate minus. The gentamicin plus in the stomach will react with the food and will form the complex of gentamicin. Gentamicin will not be coming in the blood. The complex of gentamicin will come in the blood. And that's why such drugs are to be injected only. And that's why you will always get gentamicin injection, not the gentamicin tablet or gentamicin capsule. But some of you may be thinking, Dr. Joshi, neomycin is available by tablet. Why neomycin is available by tablet? Because it should not get absorbed. It kills the gut bacteria only. The principle of the drug is actually the local clearing of the gut flora. Neomycin. Neomycin is also amine glycoside. Just trying to tell you how the basic works. The same thing, adrenaline. Can you use adrenaline by oral route? No. Because all of adrenaline, noradrenaline, dopamine and isoprenaline, 4 of them. Adrenaline, noradrenaline, dopamine and isoprenaline. All of them are having this catechol nucleus. At 4 and site 3, they are having these 2 OH groups. And when this adrenaline you are giving, noradrenaline, dopamine, this is degraded by COMT. Catechol O-methyl transfer is the enzyme present in the liver that degrades that catechol nucleus. And that's why zero bioavailability of adrenaline takes place. This is the reason, dear student, you know that my patient is hypertensive. My patient is having gut bleeding, especially stomach bleeding. Can I use adrenaline cold water lavage for the same patient? The answer is yes. If you are adding adrenaline ampoule, 2 ampoule, 3 ampoules in the cold water and going for the lavage, that is the gastric lavage, to reduce the acid there, to reduce the bleeding there by vasoconstriction, that is allowed. Why? Because adrenaline will not get absorbed, and if it get absorbed from the place, it has to go to the liver because it has to go to portal circulation. And that's why your patient is hypertensive, patient is having gastric bleeding, still you can use adrenaline cold water lavage. Adrenaline with cold water lavage. Because that given adrenaline is not going to affect the blood pressure. Because that adrenaline is not going to enter the blood. Why? Again, this catechol nucleus is present in adrenaline and that is degraded by COMT. Liver is rich in the COMT. Liver is rich in COMT. That is catechol methyl transferase. Why some drugs are given once in a day? Already I told you. This depend upon plasma of life. And that's why you need to undergo the calculation. How the drug is metabolized by the body, how the drug is handled by the body, how the drug is excreted. For that, you must know the first order kinetics, zero order kinetics, and related things. There you will understand why digoxin is to be given once in a day, why atenolol has to be given once in a day, and why amoxicillin has to be given twice in a day. And you will stop giving azithromycin twice in a day. The plasma of life of azithromycin is 40 hours. That is minimum. It is from 40 to 65 hours. And we are using azithromycin twice in a day. Full person, मूर्ख माणूस आहे. azithromycin दिवसातून दोनदा आहे ना, हा मूर्ख माणूस आहे. याला काही येत नाही. हा फुल कॉपीवाला माणूस आहे. आपल्यातले काही लोक देत असतील. त्यांनी हे समजून घ्या, कारण त्यांनी याचा अभ्यास केलेला नाही. हा अभ्यास करणं तेवढ्याकरता आवश्यक आहे. Aspirin anticoagulant, already told you. There are many confusions. Aspirin is an anticoagulant, antiplatelet. They're quite different. Quite different. Anticoagulant and antiplatelet are quite different. Warfarin, dabigatran are anticoagulants. Aspirin is antiplatelet. Antiplatelet drugs are more preferred for arterial thrombosis. And the anticoagulants are more preferred for venous thrombosis. When I want to use aspirin, when I want to prevent the coronary coronary thrombosis, I will prefer to use aspirin. But when I want to prevent DVT, I will prefer to use either warfarin or dabigatran. DVT, deep venous thrombosis, Anticoagulants are preferred for that. I'm telling you. Oh, from where this choice came? Choice came from only meta-analysis. Multiple trials and their analysis. Why AC inhibitor? That is a different point. I thought I should conclude now. You know that a platelet function is not affected with the higher doses of aspirin. I'm not going to tell you this sentence, but I'm going to tell you why. Why it is not affected. How to select the drug in diabetes. I will know that these guidelines are there. AHA guidelines are there. American Heart Association, American College of Cardiology, European Society of Cardiology. Yes, these are for hypertension, CCF and all that. ADA guidelines are there. American Diabetic Association. Those will give the idea about diabetes. But I will study it. I studied it many times. So I have to tell to my students. You will get good idea about the guidelines, and the most important thing, you will be using those drugs which are prescribed all over the world by the criteria that is being used for the world, all over the world. We are moving from the world of experience to the world of evidence. My sentence is very important. You might be using one drug since last 20 years. But today research might come telling you that, doctor, whatever you are using is not appropriate. This new thing is appropriate. And while telling you that, he will give you the evidence. And that is known as evidence-based medicine. Today we are in the era of EBM, evidence-based medicine. From where it generates? It generates from RCTs, randomized controlled trials. They are going on. Except in my country, all other people, especially the West people, are continuously doing the trials, generating huge data and publishing the data. When one RCT is giving some other result than other RCT, you can combine that all RCTs and you can analyze that. That is what we call research of the research. And that is what we call meta-analysis. And above that, some network meta-analysis is also there, where we consider different parameters. I am doing one meta-analysis, network meta-analysis now. How the drug of choice develop? Drug of choice develop throughout this thing. Yes. All this is published in the medical journals. You have to go through the papers. You just don't go. I will go and I will make all those things available for you people. so that you will be using the drug that the drug world is using. You will be using the drug in the manner the world is using. There are many pregnancy categories A, B, C, D, E, X, D and X. How they are developed, what is contraindication, where you can use the drug with even contraindication is there, all these things. You have to understand the pregnancy category. Actually, US FDA is going to discard these pregnancy categories within a year or two. That is a different thing. What is the off-label use of the drug? I should tell you one example and you will get my idea. All of you know that metoclopramide is principally a prokinetic drug useful for emesis, that is vomiting. But all of you use the same perinorm, that is metoclopramide, to increase the lactation, to induce the lactation, because it's a dopamine antagonist. Whatever the drugs, those are dopamine antagonists, are the agonists for prolactin. This is the basic principle. How and that I will explain later. But you just remember, antagonist of dopamine is the agonist of prolactin. Principle, basic. You use it, and the lady get lactation or improvement in the lactation. But this is not being this is not being written, allowed by any FDA guideline all over the world. This is known as off-label use of the drug. Now you may be thinking, Dr. Joshi, whether this off-label use of the drug is a allowed use or is a legal use or not. My sentence is very clear. I'm repeating. Off-label use of the drug is a lawful use of the drug. Use of the drug is always at the full discretion of the physician. Always. You can decide what drug I should use. But if some legal complication takes place, you should be able to explain why I use the drug. Off-label use of the drug is not the illegal use of the drug. And you may be asking me, sir, how? I should tell you very simply. 90% of the drugs used in pediatrics are converted from adult to pediatrics. Their studies are not available in pediatrics. I'm repeating, 90% of the drugs used in pediatrics are not FDA approved drugs for pediatrics because trials are not conducted. The indication is for adult, and we use the same data of adult and convert that data according to the weight, sometimes the age, to the pediatric population. And that's why 90% of the drugs used in pediatrics are off-label. Because US FDA or FDA is not giving any specific indication for the use of the drug in pediatrics. And that is why I'm repeating my words. The off-label use of the drug is not the illegal use of the drug. Now, my last thing. If you want to get the answer to whatever I told you, you should join the course, which we people are going to conduct very soon. And I think Dr. Mohite sir, Sandeep Mohite sir is the right person to talk to. With this, I think I should stop. Thank you for being with me for such a long time. Thank you.
Okay, thank you, sir.